I'm very happy to introduce our speaker, who is Jordan Scott. He's an alum of BU Medical School, so I did not have to explain to him where to park this morning, which was great. He's very happy to be back. He owns and operates a group of private practices, and he's going to tell you more about his job and his different credentials and stuff while he's talking. But this is the third time that we've had an annual Business of Medicine healthcare lecture. And this year, we decided to put it in this class because a lot of the themes relate to the things that we've been talking about in terms of health policy and healthcare financing. So we're very happy to have him. I will take attendance at the end while he's answering questions. So when you see me come back up at the end, that's a good time to get your clickers out. Thanks.
Morning, everyone. Thank you. Especially thank you for getting here at 8. I mean, I know it was required and all. I know there's free breakfast, but I still definitely appreciate it. I frankly had a hard time getting to class at 8 in medical school. So, what do? I own a bunch of allergy practices throughout Massachusetts with plans to acquire more and partnership with some other private practicing allergists. Do a lot of advocacy work as well. I'm past president of the Mass Allergy Society, treasurer of New England Society of Allergy. I'm also a clinical advisor to a number of allergy startups. One of them's inventing a new type of EpiPen that's going to last twice as long as the current device, be twice as portable, and be temperature insensitive. Hopefully that'll all work out. And then there's another device, Allergy Amulet, that actually is an allergen detection device. So if you're out at a restaurant and you're not sure if something has peanuts or nuts in the food, although they tell you there isn't any peanut and nuts, with this device, if all works out, within 30 seconds to a minute, you're going to know whether or not that food has peanuts. So we'll be preventing some serious anaphylactic reactions. I also teach residents at Boston Children's, at UMass Memorial. I have family practice residents that rotate through my private practices as well. So the challenges, I mean, in 30 minutes, I have to break down the nuts and bolts of healthcare and all the challenges we face as patients, as providers, folks in insurance, and by breaking it into these three components, we can tackle this problem, and I think definitely make things better. And whether it's private insurance, public insurance, the VA system, or whatever practice setting you're in, all these things definitely tie in. So the important thing about this slide is I don't expect you to read all this stuff in the middle, but this is all the stuff we've had to deal with in the middle for the last 15, 20 years. Since my parents were physicians too, and it's every year there seems to be more of it. And I think going forward we're going to have to make this a little simpler, because in the end the patient-doctor relationship was pretty important, but there are all these things in the middle here, and I could lecture to you for a whole semester on all these things, but we'll touch on some of them. So the insurance challenges. This is a quote from my father-in-law, who's worked for the insurance industry for decades. There's only one pie and everybody wants the whole pie, and that's basically the problem. That sums it all up. So how do we keep up with the care costs while keeping health plans affordable? It seems we're all constantly walking this fine line of restriction to the point of below standard of care. And as an advocacy for my specialty in the state, we've had a lot of very important discussions with major insurance carriers when it gets to this point. And at times it's come close, but with diplomacy and listening to reason, we've been able to keep moving things forward, in a way that works out for all parties. And especially, I think, timely and high-quality patient access is critical. I used to feel flattered when I'd book out 6 months. Now I think that was probably the worst thing I could have ever done. I had competing institutions calling me and thanking me for sending them 12 new patients a day. So, get people in as quickly as you can. I can't stress that enough. And that's the main reason why minute clinics and all these urgent care centers have been popping up everywhere and are, so successful, and why a lot of my friends in the hedge fund industry are investing in these facilities, is simply for this issue: timely and high quality patient access. And then how do we fairly and promptly compensate care systems? I have some insurers that reimburse me 25%. I have some that reimburse me 100% of my charges. It's all over the place. How do we bring more patients to a health plan? With more covered lives, costs are going to go down. And then also the image of the health insurance industry. If you talk to a lot of patients, they're pretty upset. There's a lot of pitchforks and torches lately. But I think if we all work together, we can make this better. And then the tools of insurance, there's deductibles, there's co-pays, a number of these terms we're covering, but what I've seen a lot lately is more cost shifting towards the patients. Patients will have $2,000 deductibles, $5,000 deductibles. I've seen single mothers with $10,000 deductibles, things that are pretty unaffordable for most people. So I think our system has to find the right balance where if a deductible is needed to keep costs down, what's a reasonable deductible? Is 500, is a cap at 1,000 reasonable? And these are some critical questions. I've seen people put off a lot of critical care due to these deductibles only to end up in the ER and eventually having to pay the whole deductible. We see that a lot. Or I've also seen at the end of the year all the procedures they've put off now that their deductibles met. So when you look at the whole year cycle, have we really saved any money? I'm not sure, but I think systems are going to have to look into that. Other tools are auditing care facilities. I could probably sometimes get 100 audits a week from for different charts for different insurance companies. Sometimes I have the same insurance company audit me for the last 6 months. Every time we print out the notes, we show them the work, we get paid. But there's appropriate auditing, and then there's robo auditing to the point of just to delay payments. And then provider credentialing. It's supposed to only take 30 to 60 days. I've seen it take up to a year. Even with a totally clean record, somebody who's an in-state resident, even with somebody who's moved jobs or, say, joined one of my practices from 20 minutes away, sometimes it can be extremely complex. And then also different plan options. I mean, you'll see people be able to choose their co-pays, their deductible amounts, and more important, do patients know what this all means? The term providers thrown around a lot, which sometimes kind of bothers me. I mean, we are doctors. You only train for 4 years after college, 3 years of residency, and 3 years of fellowship. You can call yourself a doctor. It's a good thing. Now, are doctors being marginalized to the point of being considered skilled labor? I mean, this is a term that's been thrown around depending on what system. I know it's a very strong and harsh statement, but I could tell you a lot of docs I know at certain systems feel that way. And then there was that New York Times article, which made me sick to my stomach, is becoming a doctor $1 million mistake. Should I have gone to PA or NP school instead? I'd say it's not a mistake, it's an investment, and I wouldn't change it. I'm extremely grateful I went to medical school. But with the cost of education, the cost of paying back your loans, and the cost of training, the liabilities, it's very easy to get cynical. Then there's always the question, well, if doctors didn't make all this money, would we save healthcare costs? And I've seen multiple papers on this issue. Anywhere from doctors are 7 to 10% of the healthcare system. So if every doctor worked for free starting now, we'd maybe save money for a year. So I don't think doctors pay is the problem. And do we have control over where we practice, what your specialty is going to be? How much I work, how much I earn, when will I get sued? They don't say if, they say when. And will I ever have a life outside of work? There's this networking site called the Dropout Club, and members, unfortunately, are going up, where it's an alternative career site for doctors and scientists who are just tired of healthcare. So these are some very cynical slides, but I want to let you know that it can definitely get better. And as students going forward, you guys will definitely have the power to change this and make this better. And when I was sitting in your shoes, I wish I had this lecture, so that's why I wanted to do it so badly. So challenges of being a patient, and these are things while we're drinking water through a fire hose, trying to learn all our basic science and do well on our boards and honor this rotation and honor that class to get into the good residency, to get into the good fellowship, to have a job, to have a chance as to where I'll practice. It's easy to forget these things. I mean, we work so hard to get to where we get, but this is what the patients go through. They don't have time to miss work. They don't have time to miss school, and a lot of them are in work and school. A lot of them may not be able to afford the visit, this test, this treatment. They can't get there. They can't wait months to take care of this problem. I mean, even for my own primary care system, I was once told, okay, they're booking out 8 months, no exceptions. And I thought, okay, I'm a physician, a colleague, and I have to wait 8 months to see my primary care. I mean, so. Do my doctors hear my concerns? I mean, ever since the electronic record, it's very easy to just click and click and click, and there's so many things they call it death by 1,000 clicks, and it's just so easy to get engrossed in the record to make sure you have the appropriate note that you forget to put down your computer and look at the patient and actually talk to them. I purposely don't go into the room with the tablet or the laptop. I purposely don't go in just so they can have my undivided attention. And I've had a lot of people thank me for that. You know, sometimes patients have to go to multiple specialists to finally figure out what's wrong. You know, everyone's afraid they may have cancer. Will they ever get better? And then who's going to take care of my family? I mean, these are the things that are going through patients' minds every day, and we see them. So as stressful as our job is, we always have to remember to put ourselves in their place. So say you take a typical office visit, level 3. You know, I've seen anywhere from $50 to $150, depending on, you know, follow-up visit. May take 15, 20-something minutes of your time. That one office visit, say in my private practice settings with about a 50 to 60% overhead, these are all the things we have to worry with. There's staff compensation, there's billing compensation for your billers, there's reception, there's facility operations, purchasing, electronic record, benefits. You know, a health insurance plan for a family for a small to medium-sized business can cost, you know, a decent plan with a $2,000 deductible PPO can cost $24,000 a year. So you have, you know, 40-something employees, half of them are on a family plan, you're talking a nice amount of money per year. And especially if you want to treat your employees well. And then there's all the other operational insurance, not just malpractice. Some malpractice insurance is $8,000 a year, some is $170,000 a year, depending on what field you go into. Cyber liability, a huge issue. Even small private practices are getting hacked now. Unfortunately, it's everywhere. The cost of supplies, too, which we're constantly keeping track of. And you always have to make sure you negotiate better rates. Coverage for national disasters, other unfortunate events. Your rent, your mortgage, your utilities, your office supplies, your medical supplies. More IT support. Security, not just for cyber theft, but supply theft, medication sample theft. And unfortunately, this day and age, sometimes angry patients and angry relatives, especially if there's a bad outcome. And continuing education costs as well, and compliance costs with OSHA, HIPAA, JCO. Your billing and coding compliance. In my practices, we have National Allergy coding expert come every year. And you know, just when we think we know something, there's always something that's changed. So it's really important to keep up with all these things. And also the cost of credentialing, continuing medical education, your licensure. Then you pay your accountants. Then you pay marketing because everyone's advertising nowadays. Then your taxes, and finally your compensation. So that one visit, there's a lot that goes into it. So back to the slide, do doctors make too much? That one visit has to pay for all those things. So how do we get through this? So basically, last few years, I've been working pretty closely with some of the major insurers in our state, at least for allergy coverage. You know, we treat each other with respect. We have rational discussions. You know, I've heard cases where people have, you know, other physicians have even threatened. My father-in-law works for insurance, and you know, said things like, "I hope you never get cancer. I hope you never get sick. I hope you never end up in my hospital when you're sick." I mean, people have literally told him these things, and I can honestly tell you, as stressful as it can be when you're negotiating on behalf of your patients, your staff, and your practices, you never want to go there. You know, you always have to keep emotion under control and be diplomatic. But it's really important to just meet routinely. And when a policy changes, get on it and call people. And eventually you'll have a Rolodex of connections of who to call. Sometimes you'll call somebody and never get anywhere, but you'll know eventually to go up to people that can help get things done. And also the big question is, do large upfront costs for patients still provide, you know, are we losing money or are we saving money? I mean, I would say that, you know, if a patient visit costs a lot and you're doing a lot for them and you're getting them better, you've actually saved the system a lot of money. So this is where I have concerns with the high deductibles. If they're delaying care, it's only going to cost more. Another aspect is physician tiering, which was a real hot button in this state, where if you're a tier 1, you're considered a good, high-quality physician. If you're a tier 3, you're a bad physician, that you cost too much money. I could tell you some of the best doctors in the state who've taken care of my family members, who I would send to in a heartbeat. Most of them are tier 3, meaning that they're considered high-cost, not good doctors. But the reason they're a high tier is because they see the sickest, most complicated cases. So in that way, I think our physician tiering system has failed us. The Mass Medical Society actually sued the Group Insurance Commission over this matter, and eventually they gave up on the suit. And Some companies have dropped the tiering system and some have kept them. Personally, I'm a tier 2. If I'm ever a tier 3, I'll fight it as hard as I can. I don't ever expect myself to be a tier 1, because if you see patients, you take care of complex case patients, you're busy, you're not going to be a tier 1. And then, I mean, most of the docs I know that are tier 1, a lot of them are part-time, some may only work a day or 2 a week. So that's where I think that system hasn't worked. And then do prior authorizations control drug costs? I think they do to a certain degree. I mean, I've seen times in my training where everyone with a cough was put on, a medicine like an inhaled steroid long-acting bronchodilator combination, or everyone with a rash was given topical calcineurin inhibitors. Yeah, they worked, but they probably didn't need it. So this is where the prior authorizations, I think, are important to help control some of these drug costs. And I could give a whole separate lecture on drug costs as well, which is a big concern now in our system. So also targeting the high cost drivers. Are some costs inevitable? I've seen some studies that childbirth is the most expensive cost, but that's going to be inevitable. And then what about tracking the hot spotters, our sickest, most complex, toughest patients? I mean, at our practices, we definitely do that, whether it's more frequent follow-ups, phone calls, checking in, looking at pharmacy refill records, are they making their other appointments? I mean, this I think is critical because they have found that just a few patients can significantly drive up costs, especially if they're in crisis socially or there's medicine side effects, all the above. And this point I think is beyond critical because I've seen models, especially when my mother was in practice, where this was beyond disturbing, where they got a collection of some of the most sickest kids in the state. They actually had a disproportionately large number of patients with Down syndrome in their private practice across the street from Boston Children's. And what was happening, and this was in the late 80s, early 90s, was a lot of the private practices around the state didn't want to take care of these patients because they were too expensive. And in their model of capitation, they were hurting the financial capabilities of their practice. So they would tell these patients, we can't take care of you, you need a more sophisticated pediatrician, and all of a sudden they got this large collection of all these kids, and then major insurers were actually calling them and saying, why are you seeing all these kids? So if we trend to a model like that, it will fail miserably, I guarantee it, and it's failed before and it will fail again. So this point is critical. We cannot create models that punish those doctors who take care of the sickest and most disenfranchised and reward those with the highest collection of healthiest patients based on the advantage of geographical proximity to affluence. It's a very charged statement, but it's very true. And I've seen some models cropping up like that again, and we cannot have that. Somebody's got to take care of the sick. Nor can we only reward for amount of procedures performed. I mean, as an allergist, I perform a lot of procedures, a lot of skin testing, a lot of breathing tests, a lot of patch testing, food challenges, allergen immunotherapy. Every one of those procedures pays money. And we track ourselves. Every month we look at, okay, is somebody doing more procedures than normal and why? Do they have sicker patients who needed those procedures? Are they doing them for the right reasons or are they doing them for other financial reasons? And so basically you have to be your toughest critic and you have to justify every single procedure you do, how is it going to change management? And if you constantly question yourself and if you're your toughest critic in this regard, you're doing it for the right reasons. Back to the tiering point, I've had some plans tier me for, say, if you get too many CAT scans. I had one plan actually send me a note saying I prescribed too many EpiPens as an allergist, but they had me listed as a pulmonologist. So it's very interesting what you see. But if you feel somebody needs a CAT scan, get the CAT scan. Yeah, it's expensive. Yeah, there's radiation, but I've had bad asthmatics who've had pulmonary emboli too. I had one asthmatic a few months ago that it was a month after orthopedic surgery and her asthma wasn't getting better. So I got a CAT scan and she had multiple pulmonary emboli, all throughout her. And thank God we picked it up. Had I gone by the algorithms, I would have missed that. Had I gone by the tiering system saying you got maybe one too many CAT scans that year, I would have missed that. But again, we have to be our toughest critics for those of us who perform procedures. And then also, there is fraud out there. There's waste and abuse, definitely. But is Robo Auditing practices constantly the right way to approach it? Probably not. Actually, I know it's not. But what there also has to be is concise and clear descriptions of billing and coding logistics. Like I said, with our practices, I know countless other practices, just when you think you know what's going on, the rules are changing so often, so you have to constantly re-educate yourself and constantly try to do the right thing. But if the rules are made clear, I think everybody can do the right thing. And again, I've asked the same question to experts and gotten 10 different answers. Which answer do you go by? The one that's the most convenient, the one that's least convenient, somewhere in the middle? So you constantly have to try to get the right information. So how do we ultimately lower insurance costs leading to a healthier population? Well, we have to have more covered lives, basically. The healthy need to be more than the sick. Tort reform is an issue that I think some states have started to look at, but it's been kind of still swept under the rug. I mean, I know there's tribunals. I know there's talks about apologizing, owning up to mistakes. Absolutely, I'm all in favor of that. But at what point will there be meaningful tort reform? You'll see the term defensive medicine thrown around. Absolutely, I have sometimes one shot to see a patient, and I don't want to miss anything. I can't miss anything. I have to bat 1,000. None of us can bat 1,000, but that's the pressures we face. And then you'll hear talks about single payer. Well, is the single payer the right solution? I mean, I've had some insurance companies that haven't paid me for 7 months, all because they were 1 digit off at a tax ID. If that was my only payer, I would have been bankrupt 6 times already, versus the growth I've experienced instead over the last 10 years. But the 42 other insurance companies I saw, fortunately, offset those payers that weren't paying for 6 months. Eventually we got paid, but it took a lot of phone calls, a lot of detective work to figure it out. So I don't know if a single payer is the right answer unless that single payer is going to operate very well. And I have yet to see that. And I think our system, unfortunately, still has a ways to go before we can make that work efficiently. Or do we do a single insurance platform with competing payers? Competition's not a bad thing. Competition, is innovation, and competition keeps people on their toes. If you have no competition, it's easy to get settled and not innovate. And then is creating more plans the answer? With more plans, is there more competition? With more competition, will this drive down costs? So this is a point I want to touch upon simply because these were inappropriate things to think of, I remember, in medical school, especially when applying for medical school, when applying for residency. But it's okay to want to make a good living. It's not a moral failing. How much do you need to make? How much do you need to make to pay off your loans, to be able to save for retirement, to be able to send your kids to decent schools, to be able to live comfortably, be able to go on vacation? I mean, these are all important things to think about that aren't stressed. They're considered sometimes a moral failing according to some people, but these are very important points. I'm going to be doing this for the next, I'm 43 as of tomorrow, so I plan to do this for the next at least 20, if not 30 plus years, and I want to be sure you enjoy it. So these are important. This is not selfish, it's not greedy, it's not lazy. You shouldn't feel guilty. It's career counseling, and I can tell you in medical school, there wasn't much career counseling. You saw what the docs did on rotation, you saw what they did at the hospital. There were certain aspects of medicine that you were never taught about. You had to sort of find out on your own. So definitely do some soul searching. It's okay, and be very honest with yourself. It's one thing to have it look good on an application. It's another thing to have it what you want to do for the rest of your life. And that's very important. Again, it's not selfish nor greedy nor lazy. It's called career counseling. So hospitals, health centers, and multi-specialty groups may be the most common practice settings, but they're not the only settings. They say private practice is in decline, but it's still definitely an option. I know very successful primary care private practices. I think one model that's going to be very big over the next few years is the modified concierge approach. I've seen cases where people pay $30, $40, $50 a month. Some of them don't even take insurance. They just have people do that. They have unlimited access. They can get people in within a couple days. They can pay their overhead no problem. The doctors can make a great living. The staff is compensated well. And something as simple as $50, $60 a month can work. So yeah, $50, $60 a month over a year is a decent amount of money, but for great access to health care, somebody with multiple medical conditions, a copay can be $50 to $100 just to see a specialist, just for a one-time visit. So there's the modified concierge option is definitely an option worth exploring. And also telemedicine, how we're going to be reimbursed. Everybody's talking about telemedicine, and there are all these committees exploring it, all these platforms and startup companies, but we're still waiting to catch up with reimbursement. I'm not aware that Medicare has come out and said we're going to pay this much for a telemedicine visit. So that needs to happen until it really goes into effect. And then also, can your practice setting give you the time to, say, volunteer your expertise if you want to? Does your affiliated healthcare system approach physician innovation? Do they own all your intellectual property if you're on faculty there? Or do you have an agreement that if you come up with something, do you get to keep a chunk of that? These are important questions that I know in medical school I never thought of, but then when it came time for fellowship, for our post-fellowship, your attending job, these are important things to ask. I mean, at some systems in this city, they're actually changing these rules now because they were literally stifling innovation, where if an institution owned all your intellectual property, at what point do you have an incentive to innovate? What if you don't want to practice direct patient care? What if you don't like seeing patients? That's okay too. With this degree, there's so many other things you can do. But I think it's also very important to be honest with yourself if you don't want to see patients directly. And finally, the services to our patients. The system, we have to make it affordable. And I think we're going to have to cut the deductibles. And it's going to be tough, but there's going to have to be a way to make this work. And then also respecting the patient's schedule, their time lost from work, from school. And lost time from work and school is lost productivity. And with lost productivity, those are people that much less likely to be able to contribute to the system and make it work. And also kindness in patients, even in the face of hostility. The visit starts with answering the phone. And sometimes when people are just feeling sick and awful, they're going to be nasty. But, we all have to just keep calm, basically, and then listen to them. Let them rant, let them be upset. They just need somebody to talk to sometimes. And then timely access, so important. Again, booking out for months may be flattering to the ego, but it is terrible for patient care. I have yet to see where it's helpful for patient care in any way, shape, or form. So these are some lessons I learned from med school, residency, and fellowship. Work hard, of course, but be nice. I can't stress this enough. I have let people go who are AOA. It doesn't matter how well you do in medical school. I mean, it matters to a certain degree, but in the end, if you are nice to people, that'll get you so much further. Some of the best people I've hired worked at Dunkin' Donuts before as managers. They were just serving people, and they were serving people from all walks of life. And so being nice is critical. I've seen some of the most brilliant physicians just totally step in it and just irritate staff, and it's terrible. So I can't stress this enough. And I'm not sure if this could even be taught, but it's so critical. You'll get so much further if you get along with others. And then remember, take time to step away from the computer or tablet, look at the patient and listen. It's amazing what you'll pick up, and you may get that diagnosis that's a life-saving diagnosis. And then respect the patient's primary concern for a visit, even if it isn't their most important concern. I've seen people with a rash who couldn't walk a flight of stairs with a breathing test at 20% of predicted value. They didn't care about their breathing test at 20% of predicted value. They cared about their rash. So I had to address the rash before we could even talk about their breathing 20% and why they couldn't even climb a flight of stairs. And it's okay to admit we need all the help we can get. Delegate. They don't teach us to delegate in med school. Or residency to a certain degree, or fellowship. But I found that if you give everyone a chance to reach their full potential, be grateful, never stop saying thank you, even on your toughest days, you'll get so much further. People will rise to their maximum potential and do great things for you and for your organization and for your patients. Some other clinical points. I don't care what field you're in. If a patient comes to you repeatedly and they're still concerned about something, and you found yourselves, you repeatedly told them they're fine, there's nothing wrong, just check yourself and get a second opinion. We've all picked up so many cases where, the patient was told they were fine on multiple occasions, and they certainly weren't. And just because you haven't seen a condition doesn't mean that it hasn't seen you. I always hear the classic, I've never seen that, I'll never see that, and lo and behold, next week they see it. And also, Dr. Brown from third year medical school taught me this. If you're concerned about something and you don't know what it is, biopsy. This will always keep you out of trouble. I can't stress this enough too. And also drug side effects. We're all taught there's side effects, but it's so easy to forget side effects. And if something's still wrong and everything's been ruled out, think medicine side effects. and make a house call. You know, people think house calls, it's like the 1800s, but no, you can make a house call, and you could do it with VNA. There's many organizations that can just check on somebody. It's amazing. One thing I loved about this curriculum is that the fourth year when the geriatric home visits, it was incredible what you saw, but there's so much you could see when going into someone's home. I've had difficult asthmatic cases. I've made house calls, and I found, say, mold in the closet of a kid's bedroom. They had seen 4 other academically renowned specialists in the city. Nobody could figure out what's wrong. It was as simple as a roof leak, a couple feet from the kid's bed. Made a house call. That's how we figured it out. And finally, we don't have to like the business side of wealth care. You'll hear terms like it's health care, not wealth care. But we all have to learn the business side, whether we like it or not, or else you're going to be taken for granted, you're going to be taken advantage of, and this is going to be cynical, and you won't have a chance to implement change. So it's really important to know whatever system you're in and how it operates as much as you can. I have plenty of time for questions. Thank you. Yes.
Explain what you said like a single platform for insurance?
Yes, so say if everybody operates under the same system, they all have similar drug coverage, they all have similar reimbursement, they all have similar contracts. Different insurance companies will use that same platform. And if they can get better rates for their patients with more covered lives, people will go to that entity. So in other words, it's like everybody playing by the same rules, whether it's billing, whether it's coding, whether it's drug coverage, whether it's hospital coverage, all the above. And a number of other countries, they've used that single platform, which I think has created less fragmentation and distortion in coverage especially. Other questions?
For learning about the business side of healthcare, I guess, what is the best way to stay up to date with changing policies and?
Great question. I've just read as many headlines as I can. I think Doximity is a great website that's ahead of this. Sometimes things that come out from the AMA as well. Look at what the media is concerned about as well. Talking to patients openly and honestly about the challenges they face, and be prepared for some tough answers you don't want to hear. I mean, there's a lot of mistrust in the system. And talking to as many physicians, mid-level providers, nurses, billers, coders, administrators who work in multiple practice settings. That's important too.
Sorry, keep asking. I'm just taking attendance while you're talking.
Could you explain what the modified concierge model is?
Yes, so basically, say you have 2,000 patients in your practice, and every patient gives you $50 a month for 12 months. 50 times 12 is 600. 600 times, having a math block here, times 2,000. Anyone have a calculator? Is that 600 times 2,000? Is that 1.2 million? And your overhead's 50%. There's your modified concierge model. And so basically, you can give timely access to a number of patients for a much, and at the same time be compensated considerably more than, say, other current models out there. And $60 a month, a lot of money? Yeah, for a lot of people is. For a lot of people it isn't. But there are models out there that are that simple.
In the modified concierge models that I've heard about, the people are paying the concierge money to sort of ensure access, right? But then they still get billed for their visits. Like
Absolutely.
If they turn out to have an expensive health condition, it's not like a capitated model.
No,
where
not
that
at all.
money's
Thank you.
expected
That's
to-
a great
right.
point. Not at all.
So if you guys were patients of, if I decided to go concierge, right, and you paid me whatever, $1,000 a year or something, what that would mean maybe is that you would get my cell number, or you would be able to get a same-day appointment, or it's sort of like having first class on the airplane, You'd be able to get a better access and maybe quicker responses about your labs and stuff, but I would still bill your insurance for the actual health care.
I mean, how much are people's cell phone bills a month? 100? 150? Yeah. So you figure, okay, 3 cell phone bills a year if you have multiple medical conditions. It's not a bad deal, especially when you have timely access.
What made you initially interested in primary care, and ultimately how did you leave residency and fellowship and kind of break into that field as opposed to staying into academic medicine?
Yeah, so actually, I'm more of a specialist than a primary care doc, but as allergists, we see a lot of primary care matters. But I actually did a pediatrics residency before going into allergy fellowship, and what actually made me go into that model was just was flexibility. I mean, I think wherever you practice, you want to have options, whether it's how much you work, how hard you want to work, where you want to live. I mean, all those guilty things we're not supposed to think about that are so important. And for me, that's what helped make the decision. Also the rotations. I mean, once you find that rotation you love, it's the best feeling ever. I mean, I hope all of you will get a chance to feel that. And for me, when I rotated in allergy, my beginning of my second year in residency, that's what I knew. I said, this is it. This is what I want to do. And some people think, oh, well, you have to go into this field to have this autonomy, to make this amount of money, to be able to have control over your destiny. I mean, pretty much any field, I think you can make it happen. You just have to find the right practice model, the right setting, and be ready to innovate, be ready to take risks, and sometimes fall flat in your face, but want more and not settle.
Yeah, and I would say too, like looking at the careers of the attendings in fields that you might be interested in, there are things about that field that won't change. Like if you hate doing surgery, you probably shouldn't become a gynecologist because you generally do surgery. But if you look at all the gynecologists that you know and they're all in like some quirky private practice that you don't like the structure of, I wouldn't let that influence your decision, because it may be that the people at the institution where you are practice a certain way, but somewhere else you could practice differently.
Yeah. There are so many practice settings.
Yeah.
So many that we're never exposed to in med school, residency, or fellowship.
You mentioned the rapid growth and sort of investment of hedge funds in minute clinics and pop-up clinics, especially in the context of providing high-quality care. What do you think about that? I mean, there might be some misaligned incentives there
Absolutely,
in terms of
there
quality
are.
and just trying to see patients.
Absolutely. I mean, or just in terms of antibiotic use, there's been a number of articles on this matter. Somebody has a cough, oh, here's an antibiotic. Somebody has a cold, here's an antibiotic. Somebody has a sore throat, they must have strep. Yeah, absolutely. There's definitely some concerns there. But again, this is all about access. When your primary care is booking out 8 months and people can't get in, or they can't get in for an urgent visit, this is why these systems exist. And one point I didn't bring across was that working with mid-levels, I think, is going to be so critical for all of us. Say you're a primary care doctor and you employ several mid-levels as well. I mean, you could see some of those most complicated cases, and the mid-levels will help you out with some of those less complicated cases. And when the mid-levels get those complicated cases, you have collaboration as to when to intervene. But if you are serving that many more people in a timely fashion, I mean, that's the reason these clinics even exist. If people are getting into their primary care within a day or two consistently, there would be no reason for these things to exist. So, I mean, I think going forward, for those of you going to primary care, this has to change, absolutely. And with the help of mid-level providers and great access, there's no reason why it can't.
And really, when you think about it, I think those minute clinics are serving a population of people like us who are employed and have health insurance through their work, and they still go to work when they're sick. So what I want is an appointment in the evening, so I don't have to miss work to go in and get my rash looked at or my sore throat looked at, because I'm still going to go to work. And ideally, you want a practice that's geared towards those patients, because you want to be able to see them.
PM Pediatrics out of suburban New York was open from 5 p.m. to like 9 p.m. and they worked like 5 days a week. They did so well. 4 hours a day work, 5 hours if you include the documentation. 5 hours a day working, if you're willing to work evenings, Monday through Friday, 5 to 9. I mean, think about it. Everybody's at work, everybody's at school. That's when they want to come in. And you're keeping that many more people out of the ER, that many more people out of urgent care, picking up some nasty things that could be hospitalized, working 5 hours a day. So 5 times 4, so you're working 25 hours a week and you have your weekends. And you're helping a ton of people and making a great living. Pretty good gig, right? Yeah. So there's many different models.
Any last questions?
Yes.
How do you think primary care and I guess the health system in general is going to try and change to adjust to the aging population in the next couple decades?
Oh, great question. I think there's going to have to be a lot of talks about quality of life, and it's a very, I know, taboo subject, but I think with a lot of generations that's going to change. You know, most people don't want to spend their last days in the hospital. So I think that's going to be a huge factor. I think people staying active and as preventative measures as possible is going to be key as well, instead of taking the reactive approach. I can tell you our healthcare system does a fantastic job of keeping people alive for quite some time. They're really good at it. I mean, I've known from personal experience with my relatives, believe me, they're very good at it. I mean, my wife's grandfather is now 100, and he's in very good health. He's at home. You know, he has a few people helping him out at home, but he's still at home. He had an aortic valve replacement at age 89, was out of the hospital in 3 days. And that was 89. You know, he fought World War II, and he's 100, and he still has great quality of life. And, you know, and some may say, well, geez, should he have had that aortic valve replacement at 89? And yeah, he was out of the hospital in 3 days, and he's lived for another 11 years, and he's had great quality of life. So, so I think, you know, people talk about, oh, is there going to be, you know, death panels? Are they going to cut us off at a certain age? I don't think it's the right approach, but I think we have to look at quality of life and continue to have very honest discussions with our patients about this. You know, people don't want to die with tubes, drains, injections, and be trach dependent and G-tube dependent and diapers in the ICU for, you know, 6 months. I mean, that's a very grim picture I just painted, but I saw that in residency. Saw that in fellowship, so I think, you know, quality of life is going to be a very important thing. And most patients I talk to, when we have talked about this, unfortunately in allergy, I don't see that much at all, thank God. But, you know, we've talked about, say, what relatives are going through. You know, people are starting to have those honest discussions. So I think things are going to change that way, and maybe this whole issue with cost is going to get a little better. I mean, there's all those papers out there that say, what, it's the last year or two of your life that, is it 80%?
Last 6 months, I think.
Yeah, last 6 months of your life, it's 80-something% of the healthcare dollars.
That's a lot.
Yeah.
I don't know the percent.
Yeah, and yeah, I mean, you should see my will. I'm pretty tough on myself. Absolutely. I'm vicious to myself. But, you know, as a provider, as an employer, and your responsibility for tens of thousands of lives from all my, you know, practices and my employees, and yeah, no, if there are no other options, yeah, I don't want to be a burden.
The other thing to think about with the elderly is in terms of some of the practice mechanic stuff that we're talking about, this is the population that has, I think, the most difficulty interacting with some of these practices where access is a problem, or you have to make calls and you have to press the right thing on the phone and you're hard of hearing. And, you know, our healthcare system, I think, increasingly sort of puts more of a burden on the patient to kind of make the calls and advocate for themselves. And elderly people sometimes have trouble doing that. You know, my aunt had a stroke. She's not that old, she's 70, but she had a stroke last year. And I just saw her this weekend, and she was discharged too soon from rehab, she felt, and she only gets 2 days of PT a week. And she was saying, I'm never going to get better, and she was really despondent. And she has money, and I said to her, you know, why don't you call up your physical therapy office and see if you could pay out of pocket for the other 3 days, so you can get 5 days a week PT in the home. It's not going to be that much. And she was like, wow, I never thought of that. And fortunately, like, she's bright, and she probably can make that call and try to sort of like encourage that to happen. It shouldn't be that hard to make that happen, and it's what she needs. But you know, you can't, if she were hard of hearing or cognitively impaired or whatever, like, it's hard to put that burden on the patient to say, call up and rearrange your care, and, you know. So that piece needs to be figured out, I think, for the elderly as we get more of them.
And I think our recommendations, too, as to what we give to patients, that's a very, very good point, is that whenever I give a treatment recommendation, I have to be realistic. It's always interesting what your American Academy of whatever specialty tells you to tell patients, and that is what patients can actually do. And I think whenever we're giving a recommendation, we all have to constantly think about that. And, you know, you may not get someone who's 100 pounds overweight, smoking 2 packs a day, drinking, you know, 5 bourbons a night to quit everything at once. This is going to take time. It's going to take earning trust and baby steps. And And, and again, back to those models that say because you have some of those patients, you're a bad doctor. I mean, those models have to change too. It's, at least for some of my severe asthmatics, if I've kept them out of the hospital for a whole year, even though they're on a bunch of medicines, that's a great goal. We've accomplished something. So, we're not going to be able to fix everything all at once, but we have to be realistic with our recommendations.
Thank you. So you mentioned using mid-level providers to help augment the care of your patients so you can get in faster, delegate some of the work. I've worked in private practice that I felt utilized mid-level providers very efficiently, but a lot of the times I got a lot of backlash from patients who wanted to, quote, I want to see the real doctor. How do you deal with that?
That could be a tough issue. We've had some patients that are still that way, but sometimes when people are that sick and they need to be seen that quickly, they're grateful for the help. We always get some patients who will say that, and I think culturally that's going to change as well. Absolutely. I mean, I could tell you as a third-generation physician, my kids have been taken care of at times by nurse practitioners during sick visits, and I don't have a problem with it. I'm grateful for their help. I mean, I think no matter what degree someone has, if they're kind, they're empathetic, they listen, they work hard, they care, they want the best for you, that's what's going to matter. And then also it depends how you say it on the phone too. Sometimes even, just asking them, say, she's fantastic, patients love her. He's fantastic, patients love him. They, people want to see them instead of the doctor. It's not what you say, it's how you say it, at the risk of sounding cliche, but sometimes that can get people convinced. And when they have a good experience, this is the other thing, they'll tell 10 of their friends what a great experience they have. They have a bad experience, they'll tell 10 of their friends. So
I also emphasize how closely the physicians and the mid-levels work together. So like in the practice that my kid and I go to, we see nurse practitioners a lot of the time, but not exclusively. So, every once in a while we see one of the MDs and you can tell that they've spoken to them about the last visit or whatever. So that makes you feel like it's more integrated.
Yeah, and we're communicating constantly as well, especially with tough cases that aren't getting better, absolutely.
Great. We do have to finish because I know the next class wants to get in, but thank you so much for coming.
Thank you
all. And thanks for eating the breakfast.